So the next topic I was asked to cover was to talk about skin and other manifestations of scleroderma. And I think tomorrow at the Meet the Professor, I will talk about interstitial refractory diseases that may be important. So I think the starting slide is a slide that my mentor, Phil Clements, gave me when I started my training with him. And it's very important to know that if a person does not have sclerodactyly, ANA is negative, and the patient does not have Raynaud's phenomenon, then this patient does not have systemic sclerosis. So I think that's probably the most important aspect when a patient is referred to University of Michigan scleroderma program. The question is whether they have systemic sclerosis or not. So all of these are scleroderma-like disorders: eosinophilic fasciitis, scleromyxedema, nephrogenic systemic fibrosis. None of them have systemic sclerosis. And here's a classification that we published now in 2013. And if you notice here, anybody who has sclerodactyly proximal to the MCP joints have systemic sclerosis. So again, I don't know whether there are trainees out here, a patient with sclerodactyly, which is thickening of the skin on the fingers versus no sclerodactyly. And this patient, so to make a diagnosis of systemic sclerosis, you do not need any skin biopsy, you do not need any blood work, nothing. All you need to see is a patient who has skin thickening over the fingers that's proximal to the MCP joint. There's only one disease that causes that, and that is systemic sclerosis. So I think before we start about the treatment, I wanted to clarify that. We further divide the involvement of skin into limited cutaneous scleroderma and diffuse cutaneous scleroderma. The most misconception amongst rheumatologists is that limited cutaneous scleroderma does not get internal organ involvement. That is absolutely wrong. Limited cutaneous scleroderma and diffuse cutaneous only differ by the distribution or involvement of the skin thickening. Limited cutaneous or crest syndrome has skin thickening up to the elbows and knees, and diffuse cutaneous has a lot of proximal scleroderma or systemic sclerosis. There are about 5 to 10% of the patients who have senesced scleroderma. In other words, they do not have any skin thickening. But apart from that, that picture is very appropriate. So before we start about treatment, the job of a rheumatologist is to figure out when did the scleroderma start. So in diffuse scleroderma, the time of onset is very clear. The patient comes and says, I was fine last year when I started developing puffy fingers, joint pain, Raynaud's phenomenon. In limited scleroderma, it is very unclear because the patients have Raynaud's for years, they have a little bit of puffy fingers, they have telangiectasia, they go to a pulmonary hypertension expert, and PAH is diagnosed. So as you define, it's very important to define when a disease started, because I told you ILD, lung involvement, cardiomyopathy, renal crisis are earlier complication. Therefore, the time starts when they start with symptoms of scleroderma, not at the time of the diagnosis. And this is what we use an educated guess. When the first symptom typical of scleroderma other than Raynaud's come into play. So the questions I ask: inflammatory arthritis, dyspnea on exertion, if they ever had a chest X-ray or HRCT, was there any interstitial lung disease? The most common symptom is puffy fingers. I developed puffy fingers a year ago, 2 years ago, things like that. Sore on the fingers, heart failure, dysphagia on GERD requiring regular therapies. People love wearing jewelry. The first symptom a patient would tell you, if you ask, they will say, I had to resize my ring. My fingers are fat, they became swollen. That's where we try to pinpoint when did the disease start. And we heard quite a bit about autoantibodies by Dr. Otis, and in scleroderma too, like myositis, autoantibodies are quite informative. If a patient has anti-topo1 or anti-RNA polymerase 3, they are more likely to have diffuse cutaneous scleroderma compared to centromere antibody, where they have limited cutaneous scleroderma. However, only 50 to 60% of the patients with systemic sclerosis have these autoantibodies. So you could have a patient who has Raynaud's, sclerodactyly, a positive ANA, and negative autoantibodies. You may want to check for other autoantibodies, but again, systemic sclerosis is a clinical diagnosis. So we talked about everything happening early on in the disease, and we will mention a little bit of progression of skin thickening. Very early disease, a doctor who came to me and said, I have Raynaud's phenomenon and my hands are starting to get puffy. Very early disease, early edematous phase. The classical fibrotic disease, which lasts for about 1 to 3 years. The skin fibrosis starts to get worse, and over time, the skin gets fibrotic, and then it gets atrophic. And a classical patient has a little bit of claw hand deformity and thinning of the skin. This is the natural history of systemic sclerosis. Who do you treat and how do you treat? So before we talk about who to treat, this is how we treat. Majority of the studies are small. Majority of the studies are post-hoc analysis, methotrexate. Mycophenolate, this is a study that Rajai is the first author he did with me. We published in Arthritis Care and Research. If they have very, very severe disease, we used to use Cytoxin. We are about to start a trial with IVIG. A patient with early diffuse progressive disease, RNA polymerase III, IVIG works really well. Abatacept, tocilizumab, or autologous stem cell transplantation. So you can look at all the immunosuppressive therapies that can be used for management of skin fibrosis. Largely it depends upon if they have underlying ILD. Then we tend to use mycophenolate. If they have inflammatory polyarthritis, then we tend to use methotrexate and one of these therapies. If they have progressive skin fibrosis despite being on mycophenolate, then we add IVIG. I think there's another slide that will come later, or did I? So who to treat got somewhere. So the patients we treat generally are patients who have early skin disease or fibrotic disease. This is a patient who has early puffy fingers. How many of you would start this patient on an immunosuppressive therapy? So my argument there would be the patient population where I would start this will depend upon their autoantibodies. If a patient has early puffy hands, and if they are topo1 positive or RNA polymerase III positive, that's a patient I would add immunosuppressive therapy. If this patient had anti-centromere antibody, I probably would not add immunosuppressive therapy. Every patient with systemic sclerosis starts with skin thickening over the fingers and gets progressively worse. You want to capture the patients early on. You do not want to wait till they have a lot of fibrotic disease. Every patient who has diffuse scleroderma with fibrotic disease should be offered immunosuppressive patient. Most importantly, patients who have atrophic disease, there is no role for immunosuppressive therapy. 10, 15, 20 years down the road when the skin is burnt out, what you treat is the skin thickening, not the tethering of the skin. Tethering is defined by hide-bound skin. The skin is soft, but the underlying tissue is hide-bound. You're not able to pick up the skin. That's not what you're trying to treat. That is irreversible damage of the overall scleroderma. Because it's an American College of Rheumatology update, I wanted to talk about a very small investigator-initiated trial we did with tofacitinib. I want to clarify, I'm not recommending tofacitinib in the management of systemic sclerosis, but all of us use tofacitinib, and this was a study based on the work that we and others have done, showing that expression of phosphorylated JAK1 and 2 and 3 are elevated in patients with scleroderma. Very small study, 15 patients, 2:1 randomization, double-blind trial. And these are the patients, again, the management of scleroderma is early disease. Tofacitinib, 10 patients, placebo 5, and majority of the patients were on background mycophenolate. So mycophenolate is a treatment of choice. If they have progressive disease, we are adding 6-month double-blind, 6-month open label, and you see that the patients with tofacitinib had an improvement in skin score compared to placebo and also a larger improvement in their function and HAQ-DI. And tofacitinib was well tolerated. So just to highlight from the ACR, this should lead to a larger trial. I didn't do that, I promise you. The other one is a drug called romikilumab in early scleroderma, which is IL-4, IL-13, which is implicated. Again, a much larger improvement in the patients who got IL-4, IL-13 inhibition compared to placebo. But the take-home message, the patients to treat are early disease. See, the patient had less than 2 years of disease duration. So this is a slide that I wanted to show before. Very early disease, puffy fingers. If they have one of these autoantibodies or tendon friction rubs, they are at a very high risk of developing progressive diffuse scleroderma. I would treat them early. If they have up to 4 years progressive skin thickening, I would treat it. These patients do not require treatment. It is not uncommon a patient comes 10 years down the road, they have atrophic skin, and people are started on cytoxin, mycophenolate. There has to be a rationale to use it at that time. Whatever you do, one thing that helps people with scleroderma to maybe improve their hand function is a good occupational therapist that you can work with. This is our small pilot study, weekly occupational therapy showing this improvement in the hand function. So the patient should be encouraged, should be referred to a good hand therapist because you do not want them to be left with a claw hand deformity. I'm going to move on to another internal organ involvement called pulmonary hypertension. Pulmonary fibrosis and pulmonary arterial hypertension are the leading cause of mortality in systemic sclerosis. So what is pulmonary hypertension? It is not a diagnosis. It's a hemodynamic observation and should lead to identifying underlying cause. The biggest issue with pulmonary hypertension is that there are different classification or subsets of pulmonary hypertension. What we want to treat and what the FDA and other regulators have approved is pulmonary arterial hypertension, and here's a connective tissue disease. The most common cause of pulmonary hypertension in scleroderma is not PAH. It is probably PH due to left heart disease. How do you differentiate? Not on echo. Every patient should get a right heart cath. Is that true here? Do you treat based on right heart cath, or how many of you treat based on echocardiogram? So I will show you the data. Echocardiogram is not specific. So the goal of a screening test is to be very sensitive. The gold standard for diagnosing pulmonary arterial hypertension is right heart catheterization. The most common cause of pulmonary hypertension is left heart disease because these patients are older. They have other comorbidities that can cause it. And then, of course, scleroderma patients have lung disease and hypoxemia. So here's the data that we just published in European Respiratory Journal with Sarah Jafar, who graduated from Lebanon doing her medical school and is applying for residency. So scleroderma patients, 260 right heart caths, where echo data and other were positive for a right heart cath. Half the patients did not have any pulmonary hypertension. If you base the treatment on echocardiogram, you would have treated these half patients that do not require therapy. 12% had left heart disease. 13% were due to lung fibrosis. So I just want to highlight, when you decide to treat somebody, make sure a right heart catheterization is done and they truly have pulmonary arterial hypertension. And this is, I just want to highlight the new definition, a lower definition on right heart cath. Pulmonary hypertension on right heart cath is a mean pressure of greater than 20. Pulmonary arterial hypertension requires a wedge pressure, which is a measure of diastolic and systolic dysfunction, and a PVR, or a pulmonary vascular resistance, that's very elevated. That's a diagnosis of PAH. Now, we heard about echocardiogram. How many of us do echocardiogram every year? And what do we do with that echocardiogram? We are biased because if echo pressures are abnormal, we send them for a right heart cath, right? Now, here's the data where we took patients with scleroderma and a low diffusion capacity and a disease duration of greater than 3 years. So they are at risk because they have diffusion capacity of less than 60%. If their TR jet or estimated pressure was less than equal to 30 millimeter, I would not have sent them for a right heart cath. But in this study, over 300 patients, 20% of these patients actually had pulmonary arterial hypertension. So just to highlight, echocardiogram could be false positive, and echocardiogram could be false negative. This is the false negativity of it. If their pressures were 36 or lower, 36% of these patients had pulmonary arterial hypertension. I think of it as 20, 40, 60, like ACR responses. Less than equal to 30, there may be a large minority who have pulmonary arterial hypertension if their DLCO is low. And this is a patient, as a rheumatologist, you look at the conclusions, normal left ventricular function, right ventricular pressure of 32, but then you forget to look at the right atrium and the right ventricle are dilated. What you want to preserve is the function of the right side of the heart, not the pressures. So this patient, despite having a systolic pressure of 32, should get a right heart cath. And here's another patient of mine where the story is over. So this is the right side of the heart, left side of the heart. This is a normal looking right ventricle and right atrium. And here is a balloon right atrium and the right ventricle. If you see a patient like this, the story is over. I mean, the game is over. There's really nothing you can do when their estimated pressure is almost equal to 100 millimeter of mercury. This is what we are trying to avoid in a disease that could be screened and effectively treated. Now, it is recommended to screen every patient with scleroderma and scleroderma spectrum by different guidelines. As I was part of the 6 World Symposium guidelines, and what we use is the DETECT algorithm. Now, I'm not going to spend a lot of time on DETECT, but how many of you do DETECT algorithm? So not many of you do DETECT algorithm. DETECT algorithm is highly, highly sensitive because it captures certain clinical parameters, the ratio of forced vital capacity to diffusion capacity. So a classical example is a patient has a forced vital capacity of 75% and a diffusion capacity of 70%. They're both declined, proportionate decline. The patient probably has lung fibrosis. Another patient has a forced vital capacity of 75% and a diffusion capacity of 40%. Disproportionate decline, the patient likely have pulmonary vascular disease. So that ratio helps quite a bit. Centromere antibody, anti-proBNP, you put this into an app, it tells you whether the patient needs an echocardiogram or not. If it tells you no, you are done for that year on screening, and we repeat it next year. A combination of non-invasive parameters and echo parameters tells us who should get a right heart cath. It's highly, highly sensitive, 95% or more compared to echocardiogram that has a sensitivity of 30%. So you want to use a test that you can send for right heart cath. The drawback of DETECT is that you do many more right heart caths. It's like a positive ANA. You do many more anti-double-stranded DNA and Smiths. So that's a disadvantage, but in a disease that can be fatal, I rather do more right heart caths than do less right heart caths. And the pulmonologists and cardiologists are moving towards what we use in rheumatoid arthritis: remission, low disease activity, and high disease activity. And that's how I look at low risk, remission, low disease activity, intermediate, and high risk. And they have moved on to look at this at every time point: clinical evaluation, exercise capacity, and the right ventricular function. And this is the data from the World Symposium. See, your goal is to keep patients in remission, like in rheumatoid arthritis. And most of the therapies for pulmonary arterial hypertension have gone to oral combination, upfront oral combination. Sildenafil, macitentan, sildenafil, bosentan, whatever oral combinations are available in Dubai and other countries. High-risk group gets IV prostacyclin upfront, but it's very important to follow these patients regularly and try to keep them in low risk. As a rheumatologist, I don't treat pulmonary arterial hypertension. How many of you treat pulmonary arterial hypertension here? So for about 5 or 10 of you treat, it's inappropriate to put them on sildenafil and bosentan and say, okay, bye, see you in 2 years. You have to follow this algorithm, and this algorithm is quite aggressive, how you follow these patients, how you escalate the treatment, and how you manage this patient population. So something that the cardiologist and pulmonologist has borrowed from us, upfront combination therapy. And in fact, if you look at the upfront combination therapies, this is a paper published in New England Journal, and this is a post-hoc analysis. Used to be that patients with scleroderma and CTD-PAH had a much worse outcome. Not anymore. If you do upfront or sequential combination therapy, the risk reduction in the CTD is similar to overall population. So early screening, early diagnosis, aggressive treatment leads to better outcomes in this patient population. I want to show you a trial that NIH did using rituximab in scleroderma-associated pulmonary arterial hypertension. It was a proof of concept double-blind study where rituximab was given in patients who had pulmonary arterial hypertension, 2 doses of rituximab or placebo, and this is a change in the hall walk, 6-minute walk test, which was much higher improvement in rituximab compared to no change in the placebo, and this was statistically significant. So just to highlight, we might be targeting dysregulated B cell activation. Scleroderma PAH is an autoimmune disease. We so far have been using vasodilators, anti-proliferative. I think we need to do a much larger trial, but it may be that rituximab and other immunomodulators may have a role that is beyond just treating early interstitial lung disease and skin disease. I'll move on to renal involvement. Again, a slide from Dr. Phil Clements, a scleroderma patient with new onset blood pressure with rising creatinine is equal to renal crisis. The key part, if a patient has scleroderma renal crisis, is that blood pressure is very, very resistant to treatment. And ACE inhibitor is the drug of treatment and choice. So who do you screen? Early disease. Majority of the patients who develop scleroderma renal crisis are RNA polymerase III. The positive predictive value is 90%. The negative predictive value is 25. So, I'm sorry, I said it other way. Positive predictive value is 25%. In other words, 1 in 4 patients with RNA polymerase will develop or can develop scleroderma renal crisis. The negative predictive value is 90%. In other words, only 10% of the patients who develop scleroderma renal crisis do not have RNA polymerase III. So if you see a patient with early diffuse scleroderma and RNA polymerase III, educate them, teach them to do their blood pressure. In limited, there's a discussion, we tell people to do it, but it's not that I focus on, and these are associations with scleroderma renal crisis. Prednisone of greater than 15, early diffuse scleroderma, RNA polymerase III, and if you see a patient with moderate pericardial effusion, those are the patients, if not overlap, are likely to develop. And this is what we give them. Scleroderma renal crisis prevention, you have been identified as a patient, your usual readings are here, call Dr. Humaira Badsha here, if the blood pressure is greater than this and this, or seek. So we give this card to them, so if they go to a ER or urgent care, the doctors are aware of what we are asking them to do. And the renal crisis management is short-acting captopril, given hospitalization if it's inadequate control, calcium channel blockers, dialysis, but ACE inhibitor prophylaxis is not recommended due to the risk of normotensive scleroderma renal crisis. And if on dialysis, wait for 18 to 24 months before considering a renal transplant. So again, If you hear my talk on scleroderma, it's all about prevention and early diagnosis. Because I can tell you, if you're not screening the patients early and diagnosing them early, then really nothing as a sclerodermatologist I can do much for them if they have severe PH, severe ILD, or they are on dialysis. So this is my last one. I think I'm right on time. The digital involvement in scleroderma. So Raynaud's is very common. I don't know if there are students here, but Raynaud's is not cold hand. It has to have at least 2 of the 3 color changes of pallor, cyanosis, and rubor. The classical finding is the discrimination, or demarcation, I should say, between the fingers. And these are the questions: are your fingers sensitive to cold, change color, do they turn white, blue, or both? The management of Raynaud's phenomenon is not pharmacological therapy. The management of Raynaud's phenomenon is lifestyle changes, cold, keep warm, stop smoking if people are smoking. And the most important thing that I apologize I didn't mention here is the core body warming. So we see people coming in Michigan, it is -5 degrees right now in Detroit, in Pittsburgh, and the patients are wearing shorts. It's snowing, and gloves. That's not what you want them to do. You want them to keep their core body warm so the peripheries could be warm. If that doesn't work, calcium channel blockers, PD5 inhibitors are the 2 that we use with antiplatelet and maybe statin therapy based on a small study from Egypt showing that it may be effective. And if not, IV prostacyclin therapy for severe Raynaud's. But most of the patients do respond to calcium channel blockers and PD5 combination along with journal lifestyle measurements. Now, here's a patient. This is usually the classical. Patients come with Raynaud's. They start to develop digital pitting scars. They start to develop active digital ulcers. Before you know, they have clear deformities, and they get ulcers at the pressure area, and some of these gets infection, amputations, and things like that. And again, the treatment, pain management, vasodilatation, antibiotics, disease treatment, and the tissue repair. Do you have iloprost available here? And do you use it quite a bit? So this is a patient population that would really benefit here from using the iloprost. And we are completing a phase 3 trial of iloprost in patients with symptomatic Raynaud's phenomenon, and also the goal to see whether we can prevent this progressive disease in this patient population. Again, pain management, and this algorithm is same as what I have shown you for the Raynaud's phenomenon. One exception, 30% of the patients with scleroderma have a large vessel vasculopathy. If you do a MRA on a patient or angiogram, they usually have complete blockage of ulnar artery. I can't tell why, but it's a large vessel vasculopathy. If you have such a patient, you have to work with the plastic surgeon to do a bypass in this patient population, and it usually helps. So if you see a patient with refractory digital ulcer, you have tried everything, consider doing an ultrasound MRA to look for the large vessel involvement. And digital sympathectomy is something that we use in our patient population if none of these things work. So I'll stop at that. I've met my 30 minutes. Thank you very much.